Hello everyone, I'm Dr. Tejasvi Chikatla, Senior Consultant Head of the Department at Yashoda Hospital, High-Tech City. Today we had a speaker who is an emergency physician from Yashoda Hospital from Delhi. She has done MBBS and MEM from Delhi. She's going to present on SCAPE. SCAPE is nothing but sympathetic crash response of pulmonary edema, where how do you management pulmonary edema in a crash situations, how do you respond to it, how we're going to manage it in an emergency situations, and how to revive the patient from the pulmonary edema. I think she's going to take us drive through it. Dr. Priya, I can take over the.
Good evening, everyone. I am Dr. Priyadarshini, emergency physician working in Yashoda Hospital. I am also an ATLS, BLS, and ACLS instructor. So we will start today with our first case. It is 6 p.m. in the emergency department, and a 58-year-old male is rushed in with sudden severe breathlessness. The respiratory rate is 40 per minute. Blood pressure is 140 by 240 by 140, heart rate is 130. Oxygen saturation is only 72 on room air. He is diaphoretic, anxious, coughing, pink, frothy sputum, and can barely complete a sentence. Now, imagine this patient is standing in front of you. What would you do first? Would you give furosemide or intubate the patient, or give morphine for the anxiousness of the patient, or start the patient with CPAP, BiPAP, and IV support, or you are going to give nitroglycerin in this patient? Keep your answers in mind. By the end of this talk, we will see how understanding physiology can change everything. What is SCAPE? SCAPE stands for Sympathetic Crushing Acute Pulmonary Edema. The key word is sympathetic. This is not simply pulmonary edema. This is an acute catecholamine surge causing severe hypertension and an abrupt rise in afterload. The patient is not drowning because they have too much fluid. They are drowning because fluid has suddenly shifted into the lungs. SCAPE is a pressure problem before it becomes a fluid problem. That single concept completely changes our management. Let's understand why and how. A sympathetic charge causes intense vasoconstriction. Systemic vascular resistance rises dramatically. The left ventricle suddenly has to pump against an almost closed doors. Cardiac output falls. Left ventricular and diastolic pressure rises. The pulmonary venous pressure also rises. Fluid rapidly moves from the pulmonary capillaries into the alveoli. Within minutes, the patient develops flash pulmonary edema. Notice something very important. The kidneys did not suddenly retain 3 liters of fluid in 5 minutes. This is fluid redistribution, not fluid accumulation. That's why aggressive vasodilation works so dramatically. Recognition must happen within seconds. I used a mnemonic SCAPE. S stands for sudden onset. Very quickly the patient deteriorates. Very quickly the patient develops the symptoms. C stands for cold and clammy. Even if the patient feels like he is having fluid in the lungs, his extremities would be cold and might also not have pulmonary pedal edema. Air hunger is present in the patient. The RR would be high. The saturation of the patient would be low. Pressure is very high in this patient, and edema with pink frothy sputum is seen. Whenever you see severe hypertension with dramatic respiratory distress, think SCAPE. Early recognition prevents delayed treatment. Let's challenge one of the oldest myths we have all learned. Pulmonary edema equals to Lasix. But ask yourself, if this patient isn't primarily fluid overloaded, why are we trying to remove fluid fast? Furosemide takes time. It does not rapidly reduce afterload. It does not immediately reverse pulmonary edema. That's why current evidence recommends focusing first on physiology. Remember this sentence. Treat the pressure, not the puddle. Diuretics may still be useful later if there is true volume overload, but they are not the first line saving treatment. So what actually saves lives? Only 2 treatments rapidly reverses the physiology. Non-invasive ventilation, high-dose nitroglycerin. Everything else is secondary. Together, they unload the failing left ventricle, improves oxygenation, and prevent intubation. Why NIV works? NIV is much more than oxygen. Positive airway pressure recruits collapsed alveoli. It decreases preload, it decreases afterload, it reduces the work of breathing, it improves oxygenation within minutes. Meta-analyses have consistently shown reduction in intubation and improved outcomes in acute cardiogenic pulmonary edema. The key is timing. Don't wait until the patient is exhausted. Start NIV as soon as possible in this patient. Now comes the game changer. If I ask when nitroglycerin dose you usually start, many will actually answer 10 or 20 micrograms per minute. That's appropriate for angina, not for SCAPE. At low doses, nitroglycerin mainly reduces the preload. At higher doses, it also causes arterial vasodilation, resulting in decreased afterload. As afterload falls, the ventricles ejects blood more effectively, pulmonary capillary pressure decreases, and the pulmonary edema rapidly improves. Levy and colleagues first demonstrated remarkable reduction in intubation using aggressive nitrite therapy. More recently, the AIMS randomized control trial demonstrated faster symptom resolution and better blood pressure control with high-dose nitroglycerin compared with conventional dosing without increased adverse effects. The evidence continues to say to start the patient with early vasodilation combined with NIV as the cornerstone of the treatment. So, after doing the treatment, we come to the investigations. One important principle is treat first, investigation simultaneously. But before that, we also wanted to know how this management of SCAPE with NTG simultaneously and NIV is done. So I'll tell you the NTG protocol, how it goes on. We start with in the second line, you can see in the left hand side, the NTG we are going for the patient has a pressure difference. If the BP is 160 to 178, we start with 600. Then if it is higher than 180 to 199, we go for 800. And then if it is more than 200 millimeter of mercury, then we go for 1000 microgram of NTG bolus. Then we start the patient in NTG infusion. Initial dose is 100 mcg per minute. And in the next minutes, we start re-evaluating the BP. If the BP decreases, we continue the infusion at 100 microgram per minute. If the BP remains same or is increasing, then we increase the NTG by 20 microgram per minute. Every 10 minutes till the systolic BP starts decreasing. Reduce NTG infusion rate by 20 mcg per minute every 10 minutes, and then we stop it slowly. So one important principle is treat first and investigate simultaneously in these patients. Never delay NIV or nitrates while waiting for reports. Our investigations have three purposes: confirm the diagnosis, identify the precipitating cause, and guide further management. Focus is my first line bedside investigation. Lung ultrasound demonstrates diffuse B lines. Cardiac ultrasound evaluates LV functions, exclude tamponade or other causes. IVC assessment provides additional hemodynamic information. ECG looks for ischemia or arrhythmias. Blood tests, we can include the ABGs, troponin, anti-proBNP, renal functions, and electrolytes. Help refine management, but should never delay treatment. Chest X-ray we can do to confirm pulmonary edema, and it can exclude other alternative diagnoses. But remember, early SCAPE can have a relatively normal chest X-ray. So how I manage the patient in SCAPE? This is by practical algorithm. Sit the patient upright, at least like 60 to 90 degree, and attach the monitor, start NIV immediately, obtain IV access simultaneously, and begin high-dose nitroglycerin. Reassess every 2 to 3 minutes. Do not start treatment and walk away. Look at the respiratory rate, look at the work of breathing, look at the blood pressure of the patient, the oxygen saturation. If the patient is improving, continue. If not, remember, many patients who appear to need intubation on arrival improve dramatically within 10 minutes. Avoid intubation if the patient is clearly responding. If not, remember to have your intubation tray ready. So what are the myths versus reality? So I will finish by busting 5 common myths in SCAPE. SCAPE equals to fluid overload? No. Usually it is fluid redistribution. NIV and nitrites should come first, not furosemide. Morphine helps? No. Routine use of morphine should be discouraged in this patient. Low dose nitrates, it only causes vasodilation. So we will start with high dose nitroglycerin that targets in afterload of the patient. Most need intubation? No. Many improve rapidly with early treatment. So I will give you 5 take-home messages. Recognize SCAPE. Okay. Recognize the SCAPE within first 30 minutes. It is primarily a pressure problem, not simply fluid overload. Start NIV immediately. Use high-dose nitroglycerin early in appropriate hypertensive patients. Reassess frequently. Many patients can avoid intubation when treated early and properly. I will end with the case now. So we're going to the case back. We have this patient of 58-year-old who has come with BP of 240 by 140. RR was 40. Saturation was 72 on room air. There was pink frotis sputum and he was unable to speak in complete sentence. We started as an algorithm and step-by-step processes by using the patient with high-dose NTG and BiPAP. And then after 10 minutes, the patient's respiratory rate decreased to 22. The BP slowly and safely started to come down to 170 by 100. The heart rate is 98. The saturation is 96 on BiPAP. The patient is talking and is able to give you the history. So, what changed? Not the lungs, not the kidneys. You changed the physiology. That's the power of understanding SCAPE. Thank you, everyone.
Thank you, Priya, for your wonderful session on SCAPE and its importance of pulmonary edema and how to diagnose pulmonary edema and how to treat the pulmonary edema. It's always important to remember pulmonary edema, it's not only diagnostic value, it is also the treatment value, which is important. And there is always a myth that we should not give NTG in the higher doses, but that is wrong. The recent evidence says that the NTG is the nitrates are the important option, which we need to start the earliest, and do not delay in starting of NIV. At the earliest start of NIV, the more better outcome and better prognosis. And that's a very good insight and thoughtful session by Dr. Priyadashni Bora. And thank you, Priya, for your session.
Thank you, sir, for inviting me.
Yeah, thank you.